Okay, guys, if you're ready, I will go ahead and hit start. Sally, you're up. Thank you so much.
Hi, everyone. Welcome. It is right up on the hour, so we're going to give about 30 or 45 seconds for others to join in, and then we'll get started. We won't hold you up very long at all. We're going to get started. Welcome. This is the HOPPS ASC final rule for 2026. We're going to talk about the updates and some readiness factors that we all need to be thinking about in any facility or center that you're at, regardless of whether you're a hospital outpatient department or a freestanding center. A few weeks ago, or not even 2 weeks ago, we did a presentation along with Vision RT under the Medicare physician fee schedule final rule. So right after, I think it may have even been the day of that webinar, CMS put out the HOPPS ASC final rule. So that's the hospital outpatient prospective payment system and the ambulatory surgery center final rule. So those come out together. They're both talking and speaking to technical only charges. And in this case, we're going to talk about that in the hospital outpatient setting. And everything we're talking about goes into effect in 2026, starting with January. So quick disclaimer, obviously every facility and every practice is unique. It's you guys' responsibility to take any payers or Medicare's regs and understand them and do everything appropriately. I skipped the housekeeping item that we are going to have a Q&A. You're all muted, but we do have a Q&A where as we go along, if you have a question, feel free to type it in. We will answer all questions at the end, but some of those, as they come through, my colleague Leah Harlan will jump on if they're a quick answer, and she will answer them as we go along. When we look at this hospital outpatient final rule, some of the highlights are the external beam treatment delivery code updates, some new surface treatment updates, the payment rate updates, which everybody's always curious about. And there was quite a section on BGRT reevaluation and the APC assignment. So we're going to touch on all of those and then speak to the readiness that we need to be getting done. So if we look at the treatment code changes, this is where all the action is happening, right? And so from the standpoint of the new treatment CPT codes, the message is the same, whether you're in a freestanding center or in a hospital outpatient department. And these codes, while they've been utilized in the hospital outpatient setting, the descriptors are different and we had deletions of codes. So for our regular treatment delivery, which encompasses everything except stereotactic today, we've got 77402, 77407, 77412. And I'm going to speak to a little bit more of those as we on the next slide. So we knew this was coming. In September of 2024, the CPT editorial panel meeting put out a change, a revision in our CPT coding. They had worked alongside with our specialties, Astro and Acro, because it was time for these codes to be revalued in the freestanding setting. And so it was like, okay, these G codes that the freestanding's been using forever with hospitals using the CPT codes, let's get everybody on the same playing field. And so what we've got is new definitions for those. There's no separate codes for IMRT. So 77385 and 77386 are deleted. We won't use those after December 31st. And all treatment codes now include the technical portion of IGRT. That's not super new for the hospital outpatient setting, but that is new on the Medicare physician fee schedule side. So when they looked at these for the hospital outpatient setting, you guys have been using the 402, the 07 and 12, but they were updated and revalued. So when we look at the comparison of this, you can see that the 77401, our superficial and ortho voltage treatment, has been deleted. That's been changed to the surface treatment that we're going to talk about in a minute. The 77402 has been revised with a long descriptor of level 1, for example, single electron field, multiple electron fields, or 2D photons, including image guidance when performed. So if you have a single electron or multiple electrons or an APPA 2D photon field, and you're doing image guidance, or if you're not, you are going to bill a 77402. So this is really interesting, and it is a shift from what we've done in the past. These codes have been around forever, the 402, 01, 07, and the 412. And it feels a little bit to me like we're going back to my young days as a radiation therapist before IMRT. So for some of you more seasoned folks, you'll be like, oh, now we're going back the way we used to be. So if we look at the 77417, which is considered intermediate or level 2, it encompasses single isocenter, whether 3D or IMRT, doesn't matter. So you could have a single isocenter IMRT patient with image guidance, and it's an intermediate treatment delivery. So that's where we really get into, hey, this is new and different from what we've done in the past. Moving on to the 77412 complex, which is considered level 3. We have a lot of ors in here. So I tell people all the time, whenever you're wondering something, read the long descriptor. It's very important to read the long descriptor because many times it will answer your question. So if we look at it, it says multiple isocenters with photon therapy. For example, 2D, 3D, or IMRT. So you could have a 2D patient that is complex if it has multiple isocenters. And then there's a big or a single isocenter photon, 3D or IMRT, with active motion management. Or total skin electrons, which we don't see a whole lot of, or mixed electron photon fields, including image guidance when performed. So this is the one that people sometimes have quite a few questions about. Isocenters play a big part of it. The active motion management plays a huge piece in this because it's not, if you're truly doing active motion management, then you are in the level 3 category, or those mixed beams and any kind of image guidance that you may do is bundled in there. So we have to really consider, and what the point was if you're using more advanced technology, more costly equipment, then that's how you get bumped into the 77412. There again, the 77385 and 86 deleted. They're gone, no more after December 31st. The 77387 is going to continue to be used. And that one's interesting in that it will be used only for the physicians that may be practicing in your hospital outpatient setting. So if your physician is in the hospital outpatient department, is doing everything that they have always done for image guidance, meaning ordering, medical necessity, documenting, signing off on before the next treatment, then the professional component of the 77387 will be billed. The hospital technical side will not bill that. The CT guidance, the 77014, which that code has been around a million years, back when we used to bill for the technical side of a or of a CT during simulation 25 years ago. It's been deleted, and port films are still hanging around. The code's still there, but there's no payment for them. So this is the big messages that you need to know and hear about the change in the CPT coding. So the active motion management, multiple ISO centers, mixed beams is where you get a complex treatment delivery. There was a lot of folks talking about, well, how many of these should we have and not have? What does Medicare expect? And, until these codes get utilized for a while, where everybody will sit is going to vary. And as a department, you really can't compare apples to apples by saying, hey, we did this many IMRTs, so we're going to have this many 412s. It doesn't work that way because IMRT could be intermediate or complex. So lots of interesting conversations going on regarding these changes in CPT code. So it will be very different for us. When we look at the treatment code crosswalk for the hospital outpatient setting, for 2D, it actually, in 25, it could be simple, intermediate, or complex. For 26, if you notice on those descriptors, it could be simple or it's probably going to be complex. 3D is going to be the intermediate or complex, and your IMRT could be intermediate or complex, depending what other technology you may be using. If you're using surface guidance at continuous active motion management on a breast that's IMRT, then you would be in the 77412. So you just got to really pay a lot of attention to the descriptors. We are giving this out as a handout. It's basically a decision tree that can help therapists. It can help you guys in training your staff and making sure everybody's on the same page. You start up the top. What are we doing? If we're doing mixed beam, electron, photon, automatically a 412, you can stop there. If you're doing photons with a single ISO center, then it could be 3D or IMRT. If you're doing active motion management, you go to level 3. So just a nice decision tree to be able to clarify a bit of the way these codes look today. When you look at the rate comparison, you have to look at it by different methods. So if you look on the far left in 25, if we had an 8.5 or an 8.6 for IMRT, you can see that could fall into either the intermediate or the complex. So big message is here to look at what these codes are paying in 2026 as a final rule. Our simple 77402 falls into APC 5621, and it's $104. The intermediate falls in APC 5622, it's $394 in the hospital outpatient. And the 412, the complex, falls at $564.51. And so if you look at that and you're comparing 412 complex treatment delivery from 25 to 26, you look at it and go, wow, it's paying a lot more. But you also have to remember it's could also be a 407 that you would bill today versus that 412 from before. So it is really difficult to look forward. And so really good idea is for those of you that are managers, take your first month and start seeing where you fall. A lot of it's going to be diagnosis driven. A lot of it's going to be technology driven. And some of it's just how your physicians treat. So really interesting as far as the way the payment's shaking out. We have to look at some of the other CPT codes that we utilize in the hospital outpatient setting and take note that hospital outpatient payment is interesting in that things fall into APCs. So you can see that the CPT codes for an intermediate sim, a complex sim, isodose, for brachy, special electron beam, a complex treatment device, or an IMRT treatment device all fall into APC 5612 and all have the same payment. And that's the way hospital outpatient payments work. They lump like services that cost about the same amount into the same APC. So if you just look at those codes, the payment rate for every one of those went up $16 for 2026. So that's really good news. When we look at APC 5611, which encompasses basic dosimetry, our simple and intermediate devices, our continuing physics, our special medical physics consults, those went up $4.55. And if we look at our IMHT and our 3D planning, those also went up. So pretty normal for hospital outpatient services to see these small tweaks. That's the norm in the hospital outpatient because everything that is determined is based upon cost reporting that the hospital does. And as things cost more, payments typically go up in the hospital outpatient setting. Not always the case in the freestanding, but in the hospital it is. So there is good news that we've had APC rates that have increased. For the surface treatment coding, since we deleted the 77401, they've given us two new code, or more than one new code actually. A single code for sim and planning, so we don't bill those independently anymore. We got a new treatment code when we're using less than 150 kV, and we got a treatment code for 150 to 500 kV per fraction. An image guidance code that can be reported only once per course, which is interesting also. So when we look at those descriptors, we see that the surface radiation therapy, superficial or ortho, treatment planning, and sim-aided fill setting, one code defined as 77436. And we look at the two treatment delivery codes. We got the lower energy at 3.7, the higher energy at 3.8, and then the 77439, which tells us surface radiation therapy, superficial or ortho, image guidance, ultrasound for placement of radiation therapy fields for treatment of cutaneous tumors per course of treatment. Notice it says per course of treatment, which means you only bill it once. List separately in addition to code for primary procedure. So you would bill your 77436 as done, treatment planning sim. You bill your two treatment, whichever treatment delivery code, and then your 439 if you're utilizing that ultrasound for placement one time per course. So totally new codes for January 1, 2026. Overall, if you look at the hospital outpatient payment rates, they increased by 2.6%. And that's overall. That's not just radiation oncology, that's hospital outpatient as a whole. So this increase does include a 3.3% hospital market basket increase and a 0.7% productivity adjustment, which means it was less. That's how we got to the 2.6%. And CMS continues to give hospitals a reduction of 2% if they don't meet their quality reporting requirements, because CMS is very driven by quality reporting in both the hospital and on the physician side. BGRT, there was a 2 or 3 pages of BGRT conversation, lots of comments. As you guys hopefully know, when the proposed rule comes out in July, Medicare is giving us, this is what's proposed for the following year. People can comment. We always encourage everyone to comment. They a lot of times publish those comments, and that's how we bring to light issues that may be incorrect. So there was a lot of talk around this, and the reason being is because this biology guided radiation therapy, those codes started as C codes back in 2024, but with a payment rate, which was very good. And then they stayed in C codes through 24. Starting in January of 25, they actually moved to these G codes that you see here, the G0562 and the G0563. And so when they set payment rates for 26, they're using 2024 cost reporting and claims utilization. Well, there wasn't claims for the G codes in 24, right? Because in 25, because they didn't start till January of 25. So they had to use the C codes, lots of back and forth on that. Ultimately, they settled on these two APCs with these two payments. They are expecting more claims data. It was low volume. So they have a low volume APC policy that they use. As that technology continues to grow, we will see probably more variation in payment rates because there will be more claims data to use. So very interesting reading if you're a little bit nerdy and like to know that kind of thing. Let me know. I'll be glad to make sure. In fact, we've got links to the final rule. And if you decide you want to read 1,400 pages or 2 or 3 before you go to bed to put you to sleep, you can certainly do that. From the direct supervision standpoint, CMS just revised that definition to include real-time video and audio. Same thing in the freestanding center. All good things for our specialty, particularly for our rural centers. There may be a few of you that happen to be in non-accepted off-campus provider-based departments. If you're one of those, then you probably understand that. That means that you are off of the hospital main campus. And a number of years ago, they made those campuses bill the G codes, and the payment fell under the Medicare physician fee schedule, even though you were a hospital department. So the message come up, okay, what about these non-accepted off-campus provider-based departments? Do they change to the new CPT codes? And the answer is yes. In all circumstances, we will be using the 77402, 07, and 12. But if you're in that off-campus provider-based department, you will add a PN modifier to those claims. And that just lets the payer know that the payment rate will be under the MPFS. So that's one of those confusing things where they're combining HOPPS and MPFS in an interesting fashion. This is the links to these final rules for the hospital. And there's a fact sheet on there that CMS does too. Great information for people to know. As I said, you will also have that decision tree and one other document from this webinar. So thinking about those things, which are the top things that are affecting you in radiation oncology, the readiness list is pretty big, right? We have to update all CPT codes and code sets within your EHR. You have to be doing that. If you're a hospital outpatient setting, you already have those in there, but come January 1, you're going to have to make sure that you're not billing any of the IMRT codes. Make sure that your physician orders and any patient estimate forms. We've got to worry about our prior auths, and we've got to check fee schedules. So when we look at those things in total, obviously if you're in ARIA or Mosaic or RayStation or whatever system you're using, just make sure your code libraries are up to date and that you're ready to utilize those appropriately. Whether it's in Epic or anything else, and make sure your charge masters reflect correctly, because your 407 may have a different payment rate in your system than it should have come January 1, because remember, you've been using those codes, but they've been revalued and they have different payment. So you want to make sure that you have your system set up correctly. Your physician orders need to be very clear. This is nothing new. If you've got folks in your department doing prior auths, they need to understand these new CPT codes and what to look for in physician orders so they know what to auth come 1/1, right? Um, Other documents don't change. One of the things that people have asked is, okay, since everything's bundled, then we don't have to with with any of the image guidance, we don't have to follow the same rules. Well, yeah, you need to. Nothing really changes in radiation oncology as in any medical. Physician orders are key. Medical necessity matters. Make sure your physicians talk about that. Even though now we're not billing an IMRT treatment delivery, should the physician state why they're doing IMRT? Yes. And that's not just for billing purposes, right? That's in the event something bad may happen and you're standing on a witness stand, right? Like there is really importance in our medical record, very much reflecting the work that we do, right? Uh, Surface guidance, active motion management, any kind of imaging that's done needs to be ordered, reviewed, signed off on by the physicians. And Ben's going to talk about that here in a few minutes of some easier ways to do that with surface guidance and Vision RT, and patient estimates to make sure we have the latest codes on there. Prior auths are going to be a little bit tricky. You know, almost all of the Medicare Advantage plans require us to get a new auth anyway. They expire at the end of the year. In our centers and for our clients, we're making sure that the payers are ready. Most of them already have these codes, right? So that shouldn't be much of an issue. This is an AMA CPT thing. So they've got these new updated codes, but it's always a good idea to give your particularly smaller commercial payers or like your Medicaids, are you going to be ready for this change and paying us differently because they were revalued? And getting new auths is vital. So you don't want to not get paid come January 2 because you didn't update your auth with a different treatment delivery code. So if you've authed IMRT through December 31st, now you've got to look at that patient and go, is it a 07 or a 12? And auth it for the rest of January. So make sure that your prior auth folks are aware of these coding changes too. You know, doing training with your entire department on these changes, physicians, therapists, dosimetry, whether it affects them or not, right? They're going to hear about it. Your prior auth folks, any coding folks, make sure you get everybody up to date. There again, I think one of the questions, should we expect delays in claims processing? I would hope not. We've been calling payers at some of our clients, and most of the payers are saying, hey, we've got these codes. Now, they might not be able to give you a definitive answer on come January 1. Medicaids, like I said, I think a lot of Medicaids may not be ready. And looking at your fee schedules, do they need to be renegotiated? If your fee schedule with a payer isn't based on a percentage of Medicare, then yeah, you do need to look at those rates because you may get paid less for 77412 than what even the Medicare allowable is. So whenever these type of changes happen, it's not just about choosing the right code, it's looking at the big picture. Because as radiation oncology as a whole, we want everyone to do really, really well, right? We want people to bill appropriately and we want them to get paid appropriately. All right, I am going to quit sharing and I'm going to let Ben talk a bit about Vision RT and some documentation for surface guidance.
Excellent. Thank you very much, Sally. That's a great overview, as always. And thank you to Leah as well. We've had a lot of questions come up in the Q&A. So Leah's been very rapidly going through all of those questions. So please keep posting those as well. Anything we don't answer in the chat, we'll have a chance to talk about afterwards. But yeah, as Sally mentioned, I wanted to touch on really how Vision RT can help with supporting active motion management and the required documentation to really help support reimbursement. So I think it's fair to say it's been a really exciting time for SGRT over the past few years. We've seen the clinical adoption of SGRT and the use cases really expand. I mean, there's many sensors now that have gone completely tattoo-less, really depending on surface guidance to help position and track the patient during treatment, which of course is better for the clinics and especially for the patients. But now with these new latest reimbursement changes and updates, I think it really strengthens this statement at the top of the screen, where it really is the time now to consider equipping every LINAC with SGRT. There were several questions in the chat actually around this, whether or not surface guidance is a form of active motion management. The answer is absolutely yes. There are, of course, some little additions to that statement. Namely, the physician needs to determine the medical necessity of using active motion management in order to be able to bill at this level 377412 code. And also, as I'll touch on in a moment, we have to make sure that we're documenting this and we're getting the appropriate sign-offs. But before we get into those details, I did want to start off talking about the SGRT solution from Vision RT, which I'm sure many of you are familiar with, is the flagship product Align RT. So this is active motion management. It's actively, continuously, in real time during the patient's treatment delivery, tracking the position of the patient and allowing the user to pause the treatment if the patient moves. So this is active motion management. It can be used as a setup tool. One of the questions was, if we use Align RT for patient setup, but not for monitoring, does that qualify as active motion management? In that case, the answer is no. You have to be actively using Align RT during the treatment delivery as well. But I'm sure most of you are aware, Align RT uses 3 ceiling-mounted camera systems to track the patient's position in real time. There are many benefits of Align RT. I'm just going to touch on some of the highlights that we've kind of grown towards in our almost 25-year history now. So Align RT is the market leader in surface guidance. We're very proud to have more than 3,000 clinical systems in use, which means we've got tens to hundreds of thousands of patients every single day being treated using Align RT for real-time motion management. And then we're also very proud that 24 of the top 25 centers, best hospitals for cancer in the US, use Align RT as their SGRT solution. There's also benefits beyond some of the other clinical benefits and the reimbursement opportunities that are coming up of using surface guidance, and that comes with efficiency. So just using Align RT and the real-time deltas to track the patient's position, there's several publications showing that the amount of time the patient spends on the treatment couch is reduced by around 22%. And then if you're using postural video, which is this real-time video feed that's shown on the screen here, if you're using that for patient monitoring, setup, and during delivery, this can further reduce the amount of time it takes to set up and treat the patient by an additional 25 to 40 seconds every single fraction. So you can see how this quickly adds up throughout the treatment day, and the efficiency benefits of using SGRT, I think, are pretty clear based on this. Vision RT also has a philosophy of being completely agnostic when it comes to compatibility in different treatment environments. So we have interoperability programs with all the major LINAC vendors. We offer beamhold capabilities on all the major LINACs. And this really allows you to have a standardized SGRT solution, even if you have multiple centers, multiple LINACs that are maybe of different vendors. So we like to remain completely agnostic in that regard. And then finally, this opportunity, the clinical benefits of SGRT are intended for every single patient. So in order to get that sub-half millimeter tracking accuracy, it's really important that this works for any patient that's being treated. So we've taken a lot of time to ensure that we get the same level of accuracy across a wide range, all patient skin tones, and also that the system works. If the system's down, you don't get the benefits from SGRT. So we have a 99% uptime target for your system, for your Align RT system. Now, one of the important caveats about using SGRT as active motion management really is, I think, highlighted by this little quote at the top, which I really like, and I stole this from the SGRT super user Mike Torhammer. But basically, if you didn't document it, you didn't do it, according to any auditor. So we have to get a really clear path of documentation, and that's really going to be critical for these new reimbursement opportunities as well. So any of you that have Align RT today will know that one of the features of Align RT is that for every single monitoring session you have, so any fraction where you're using Align RT, there's a treatment report that's automatically generated. So this report is customizable. You can configure it however you like. There's an opportunity to type in a statement that can be canned code, canned wording, or that can be changed for each patient. And then there's information about how the patient was moving during treatment, were they stable, whether the treatment beam hold was needed at any point if the patient moved out of position. So it's a really good record of the patient's compliance during treatment and that active motion management was being applied effectively. So this is available and has been in Align RT for a long time. There's a new module that's just been released that automatically allows this report to be taken from Align RT and automatically moved into the OAS. So this is where your physicians can have this in their list of images or documents to approve, such that it can be part of that permanent record for reimbursement and other purposes. So just taking a look at this new module called OAS Reports module, as I mentioned, as soon as the treatment monitoring session with Align RT has completed, the PDF report is automatically generated, and then OAS Reports module automatically takes that PDF report, converts it into DICOM format, and then pushes it over to the OAS where it's consumed and it shows up under that patient's documentation in the appropriate location. So this is compatible with ARIA and Mosaic, and it's a fully automated process. So if today you're taking that PDF, manually sending it across and putting it in the patient's document list, that's a process that an individual needs to take time to do, and it's possible you could miss a few of those reports going over, which in the future will impact your billing. But OAS Reports module completely automates this. So in the example of ARIA, any of the end of treatment reports and screenshots that are captured during the monitoring session will show up in the correct chronological order within the patient's ARIA timeline. So in this example on the screen here, sitting next to the rest of the patient's treatment. So we have a CBCT, we have the actual treatment record of the patient's treatment delivery, but now with OAS Reports module, we're also seeing these screenshots and the end of treatment report that document that active motion management with Align RT was used throughout this patient's treatment, and it can be used to refer back and for these reimbursement changes as well. So this is an automated process. These can be configured to require physician approval or not, depending on your needs. But these can show up in the same list of approvals that we're seeing for physicians, whether it's a KV, a CBCT, and now also for Align RT monitoring of the patient. So that was just a really quick overview of how Align RT can be used to very effectively and efficiently provide this level of active motion management, and also how this new OAS reports module can be used to really facilitate the documentation requirements for billing, particularly that 77412 code. So with that, I just like to pass back and we can go into a Q&A session.
Sure, I will start with one of these, and it asks, and I think I touched on it when I spoke, but probably not clear enough. When billing any of those CPT codes, particularly the complex one, will it be site dependent? Well, we don't want it to be, right? Like, because one person doesn't treat one rod doesn't treat every breast the same way they do another one, right? So we have to read those descriptors, understand the technology that we're using, and then make that determination. The worst thing that could happen would be, benefit management companies or payers saying this diagnosis is only simple, or this diagnosis is only intermediate, right? Because that wouldn't let us utilize the technology that we do today and bill appropriately. We will be giving you the slides. And I think we touched quite a bit on the fact, but it kind of keeps coming up, is on the image guidance side. So image guidance can be billed 77387, whatever the technology, professional only by the physician, not by the hospital. Will billing the 77412, I think they're asking, will it be higher than what CMS predicted of 35%? And that was in the Medicare physician fee schedule rule. And will it trigger audits? What we need to understand is under the Medicare physician fee schedule, when they spoke about these new CPT codes, they have to have a balanced budget. So when they assign payment, they had to look at radiation oncology and go, where do we expect or think these codes may fall? The actuality is we're not utilizing them yet in the fashion that we're going to become January 1. So we don't know. And they also stated in that other rule that they would be re-looking at all of those codes after the first 6 months. So I would say that is a wait and see. Leah, did you want to answer the multiple ISA centers include 2 separate 3D sites?
I sure will. Sorry, it's taken me a minute to get my camera to come on. Maybe. I don't think my camera will launch. So on the 2 separate 3D sites, that is 2 separate ISO centers because you've got 2 sites. So that would be a complex 77412.
That's a good question because you got to think about it different ways, right? Or it could be one site with multiple ISO centers. Right. But there again, the point is that you're utilizing more resources, taking more time, so therefore it should pay more and fall into the higher category.
Correct.
Will the Medicare OS need to be done before January 1 or should be done on January 1?
So I wanted to answer this live because that is a very payer-specific question. So far, we do know for sure that Evolent will be ready sometime in December. They don't have a date yet, but they will be ready sometime before January 1st that they have told us to accept their 2026 auths that include the new CPT code set and everything like that. Historically, we have had some Medicare Advantage payers whose auths expired December 31st that would not let us submit the auth for the new year until January 1st. So this is something that you have to stay on top of your payers. Your prior auth team is going to have a lot of work ahead of them between now and about January 15th. Unfortunately, all Medicare Advantage typically needs a new auth at every calendar year already. They typically don't issue auths that cover from one year to another. But you also got to look at your commercial payers this year. So it is a bigger lift on your authorization department. Just keep that in mind when you're planning for staffing.
We've been told technology does not necessitate using 77412, which it doesn't. I mean, 77412 has many ors, right? Like the mixed beam puts you at 412. But that active motion management has to be on a mobile target, example, no head or neck or pelvis. And then there's the next one says, can we bill vision RT on prostate patients? There's probably several of those.
You want me to take that?
Sure.
Okay. So medical necessity has to be a driver. It's always been like that. And the only person that can determine that medical necessity is your physician. We are anxiously awaiting Astro's guidance on what active motion management is in their opinion. But unfortunately, we don't have that yet. We are expected to have that come January 2nd when they release their 2026 coding guide. But bottom line is the physician has to determine that medical necessity. And then you've also got to look at your payer policies to see what is covered and what's not.
Yeah, I agree with you on that one, Leah. You know, everything is physician driven. And just because you utilize something doesn't necessarily mean you're going to bill for something also, correct? So, you know, I think it's going to be kept a little loose because there again, one prostate may not be another prostate, right? But when we're talking active motion management and the medical necessity of that, I am sure a lot of payers are going to be going, oh, intrathoracic, sure, intra-abdominal, yeah, right? Like they're going to be wanting to cookie cutter it, like we said, into diagnoses, which we would rather them not, because not one patient equates another, and physicians do treat differently. When you say actively using, does that mean using the beam off feature, or can it be just monitoring while treatment without the beam off feature utilized?
I think that's a question about whether or not it's required to have the automated beam hold
Yes.
for patient monitoring, or whether just manual beam hold is acceptable. So I know the answer is both are acceptable, but Leah, I don't know if you want or have anything else to add to that.
I don't. They are both acceptable as long as you have that mechanism and you also are using that mechanism. So you can't have it just, tell you that the patient's out of range and you do nothing about it every time.
Agree. Actively monitoring that motion. It's very important. Okay, for IMRT patients, we are not creating vision RT report because IGRT charge was billed. Now with the change for professional IGRT, do we need to capture vision RT reports for IMRT patients as well? Okay, so let's not even think about IMRT patients because in reality, from the treatment delivery standpoint, doesn't matter. But if your physician is going to bill for any of the image guidances, whether cone beam, stereoscopic, active motion management, surface guidance, that physician will need that report and signed off on before the next treatment. So the answer is yes. Documentation very. Do you have a Groupon for the documentation module? I like that. That's funny.
I like that one.
We've got to be humorous when it comes to technology and particularly billing about technology, right?
Yes.
Lots of same questions up here. Do the doctors need to write something to charge the 77387? They need to order it, put in the medical necessity, and document that it was done by the utilization of the OIS report or a manual way or a signing of a cone beam image, whatever it is they're doing.
And don't forget that to bill that on the professional side, it's before next beam on too.
Yeah. Medicare reported, it moved on me. I lost it. Something about Medicare stated that some facilities could not bill 77387, but still should report it for statistics purposes. In the hospital outpatient setting, that has been the case for some time, that image guidance was bundled. So that hasn't changed on the except for January 1, because the CPT code says image guidance is included. So you don't need to report it, but the physician side would. If a breast patient falls under 77412 for active motion, would the boost plan that follows after fall under 412, or would we need to charge the 402? So it's going to be about what you're doing, that treatment. So if for the boost, it's electron, one field, no motion management, no anything else, it would be a 402. So you have to look at each treatment that you're delivering on its own. Are SVRT or SRS still billed correct? They don't fall under these codes. These codes are not about stereotactic. Change nothing with your stereotactic treatment delivery. Since imaging is included in all treatments now, does that affect anything with insurance denying imaging? Is there another code for this? If you've been billing imaging, then you've been billing it through the Medicare physician fee schedule and freestanding or for the physician, would be my assumption there. So you're still going to be doing that. And if you're billing professional only or global, and we're probably still going to have to fight those, is the reality. How do most centers justify SGRT on each patient? We currently have it just ordered by the physician within the RX imaging section. Is there more documentation anyone recommend as we move into using SGRT on each patient? So I think that's a couple of fold question. I mean, Ben gave you some great statistics and reasons to use SGRT just from if it's a patient that you're not as worried about active movement of the tuber volume, but you're using it for productivity. Well, it's ordered, but it might not be billed, right? So is the medical necessity there? So, the last thing you want to do is, start adjusting everything that you do based upon coding. That's never a good idea. Can you use motion management on electrons? Or would the cone be in the way? That's a Ben question.
Yeah, so there are definitely workflows. Obviously, a line RT tracks the patient's position using a region of interest. If that region of interest is completely occluded by the cone, then we wouldn't be able to see the surface. However, if you design your ROI such that the cameras can see it, then absolutely you can use a line RT with electron treatments.
If we bill 77412 for an IMRT prostate bed, so that's assuming that you're meeting some criteria for 77412, because IMRT alone doesn't get you there, and have a boost plan that is IMRT, what do we bill for the boost? There again, the IMRT could be intermediate or complex. This is dependent on the other factors. So you just got to read the definition and figure out where you fit and what technology you're using. So we will now need to change any 8.5 or 8.6 to 4.12. Not necessarily, because 8.5 or 8.6 IMRT could be intermediate or complex, depending on read the descriptors of the code. But we are charging 412 for active motion management. Yes, if you would meet the definition of 412, if your physician's ordered, it's medically necessary, and you're using active motion management. Do we capture reports from 25 for now, or do we just capture the reports for 26? Honestly, you should be capturing the reports in 25 if there's any billing being done from the active motion management side. Currently, we'll bill one of three IGRT codes, 77387, G601, G6002, and G6017. On the professional side, we will still do this. No, you would only use the 77387. Freestanding center, we own equipment, docs do their work. We should be able to bill global for imaging, correct? What they did with the 77387 was it's always had a professional and a technical component to it, which equates to global. What they did was they changed the RVUs to be the same no matter if you bill it globally or professional only. But the reality is the treatment delivery, treatment code descriptor includes the image guidance now, regardless of which type you're using. So you should be billing come January the 77387 with the 26 to be really correct. But if you drop the modifier, it's still going to get paid the same. All right, we are about out of time. Is there one or two? Is there another one or something we should do here? Breast IMRT with SGRT, single isocenter. So that puts us where? Two fields, would that fall into the 407? Correct. Because you're meeting the criteria of IMRT. Well, with SGRT, if you're doing active motion management, ordered, documented, medically necessary, then you would fall in the 412. All right, and as we said, we will be providing you the slides, the decision tree, and a document that outlines the readiness. And from the standpoint of RBS, we certainly appreciate your time. I love the questions. Like I said, we've all got to keep informed and document well, bill correctly, no matter where you're at, what you're doing. And if there's anything else that we can do for you, certainly reach out. Ben, do you have anything else?
No, not really. Yeah, thank you again for everyone for your attendance and for all the really great questions. I think that's been a really good, lively discussion with the questions coming in. And yeah, thank you again, Sally and Leah, for supporting this and providing all this great information. There's a lot to digest, but I think you've made it really, really clear. So thank you both. And yeah, thanks all for attending.
Absolutely. You guys have a great day.
Thank you. Bye.